Welcome to Healthcare IT Today. I'm John Lynn, together with my colleague and friend Colin Hung. The world of technology and healthcare, ever changing in new and novel ways, and that's why we love this stuff. So join us as we discuss the latest healthcare and health IT news, meshed together in new ways, which help generate ideas and new perspectives. Plus, we'll have a little fun along the way. Today, we're going to be taking a deeper dive into healthcare AI. And be sure to follow the show on social media at the hashtag HITSM and our personal accounts at TechGuy and at Colin_Hung. Plus, check out our 20 years of health IT content at healthcareittoday.com. You know, it's interesting that I have such a deep, sexy voice right now because I don't know if AI can help the fact that I have a cold, right? And a cough as we're recording this. You know, I've thought about doing some searches, should I be doing it to make sure that I'm healthy for the Vive conference in a few days? But,
I
it's
was
interesting.
I was just about to say, John, hey, you got a pretty good filter on right now, a voice filter on. Like you, we should
Well,
bottle that and offer
you
that.
like you like the deeper voice? Is
There you
that
go. It's like the deeper, raspier voice. It's definitely something fun. No, yeah. I mean, AI is a topic we've spoken about a lot. Interested to go deeper into some topics and some sort of corner areas of AI, and because I think we've all heard a lot and maybe too much about some of the stuff in the mainstream of AI and healthcare. But let me just dive right in, John. So this is the first one. Do you think hallucinations, John, will A, continue to happen, and B, will it be something, if it is going to continue to happen, will it be something that stops AI from being fully accepted or implemented in healthcare?
Yeah, I think it's pretty clear, and I think all the AI scientists are saying the same thing, which is hallucinations are a feature, and that you can't like really do away with them using the current LLM technology. Like that, it's going to continue to happen, and certainly you can review it, you can check against it, you can do RAG, retrieval augmented generation, you can do different techniques to minimize the damage of a hallucination happening, but you're never going to have the hallucination stop. So it seems pretty clear that that's going to be the reality. So, it's interesting then. Okay, what does that mean, right? Like, I don't know if do you agree they're going to still happen?
Yeah, I will. Yes, I don't pretend to know the science, but from what I'm reading, it does not appear that with what we know today, even with the advances in quantum computing, that this is going to go away. It's just something seems fundamental in the way we've built our AIs today. Now, down the road, we may come up with a new way to build AI or some new thing, but for today, for what we know today, yeah, it does appear to be a permanent feature.
Yeah, and that's how I feel about it. People are like, well, it's going to hallucinate. So they're like, throw it out. And I'm like, well, there's 2 points to it. One is that, okay, it hallucinates, but if you pair it with a human, humans can evaluate the hallucination. And that's what we see in so many different of the applications, including the note creation and documentation stuff and the note summary stuff that's happening in pretty widespread use in healthcare. And so it's like, sure, could it hallucinate? Does it hallucinate? Yeah. Is it causing dramatic damage? No. In fact, it's actually accelerating a doctor's ability to create notes. It's accelerating their ability to summarize the entire paper chart in a way that is more effective than them scrolling through 30 screens and 40 documents and 70 lab results, right? So it's like, as long as it's paired with a human, and then you do some other things to try to prevent hallucinations, and you link to the original references and all of those types of things, that's not such a damaging thing given as a co-pilot, right? As it having it next to you. But then I think the bigger thing is what you kind of hinted at, which is there's going to be other opportunities. Maybe it's not LLMs. It might be some other AI. It might be some other, and maybe quantum computing opens that up, or maybe it's access to better data that opens it up. Or maybe it's smaller models. Smaller models with better data could produce better results, and not as an LLM, but as some sort of AI solution that solves the problem. So to me, both of those are the promises, even though hallucinations are scary and they draw in the headline, right? Like, oh, it hallucinated, and we're going to hear that it hallucinated and someone lost their life, right? Like that probably is going to happen the same way EHR downtime eventually led to someone losing their life too, right? The same thing is going to happen. But on the whole, I would say we're going to get more benefit than damage that's going to be caused, and it's going to continue to evolve.
Yeah, yeah. I mean, to me, I don't think it'll stop AI from being implemented. However, I do think that um, it, in some cases we may over-engineer for the hallucination, meaning
Mm.
we'll be too cautious and put in too many double checks, where maybe we didn't have to have as many. Um, because in healthcare it is a life and death. Now I'm not saying it's wrong. I'm just saying that we will be constantly having somebody to double check things and look at things in order to catch the few times where the hallucination does happen. So yeah, I don't think it'll stop it from being implemented, but I do think it'll stop us from ever turning the switch over to the AI, right? That kind of deal. So yeah,
Yeah, it's interesting too, because if you think about it from a clinical standpoint, there's a different bar than the RCM, for example.
right.
Like if you screw up and you pay a payer too much, that's fixable, right? Like you could do that. Or even if you charge a patient too much or vice versa, right? You don't charge them enough. Like those are fixable things. But well, on the clinical side, that's where we get more concerned. So it depends
Yeah.
on where it's being applied as well.
Yeah, absolutely. You're right. I mean, I think on the administrative side, we're definitely going to err on the side. Well, we'll implement it and we'll figure it out. But on the other side, the clinical side, I don't think it's going to be carte blanche for AI. Which kind of actually, John, leads me to the second question. We might as well get right to it, which is, do you ever think healthcare will trust AI agents without supervision?
Yeah, I mean, it somewhat goes towards what we just talked about. Depends what area. On the clinical side, it's interesting. I would have said no, but in the last weeks, month, maybe, we're starting to see more and more startup companies come out. And they were always afraid to say, hey, we're going to be Dr. LLM or whatever you want to call it, right? And now they're saying it. Like every one of you needs our doctor in your pocket. And so that's going to force a culture change in what we expect our AI to do. So I mean that's interesting to see kind of them trying to push that boundary. So it'll be fun to watch. Are people going to kick back against it? I don't know. But in the RCM side, I think we are going to do it. We're going to have it work without supervision. We're going to have it go and reach out to every single patient and understand why they're not paying their bill. Like, why not? And then there probably will be some examples where they call someone who's loved one passed away or different things are going to happen. There's going to be some damages that come from it, but I think we're going to see, especially on the administrative side, where AI agents are going to work autonomously and without the supervision.
Yeah, again, I think you're right in that for administrative tasks where if it does go wrong, it's still fixable. I think people may err on the side of let's just use it without supervision, not because they want to, but because from a cost perspective, they have to. I mean, that's why they're implementing this in the first place. They have no one that can do the job, or no one wants to be sitting there minding that role. So we'll just outsource the whole thing. And the damage, although not pleasant, is at least repairable, right? I obviously don't think this is going to happen on the clinical side anytime real soon, because that's opening yourself up to way too much liability and lawsuits that no one wants. The risk is way too high there. Where it gets interesting is that gray area. Would you ever do this with a triage, like a voice system that's handling calls into a hotline, or that's doing calls to determine what level of care you need? So you set up an AI agent, it's running up against, answering like what hours are you open, where can they park, and then you get a call on someone who's actually got an emergency situation. Is the AI going to be smart enough to know, oh, hey, listen, you need to hang up and call 911, or is it like going to try to do something, right? Is it going to route it to the right person or write it to the right place? And that's where it gets that kind of gray. It is actually a life and death situation, potentially. But it was in an administrative area, a place where it wasn't expecting to get one of those types of calls. Anyway, I'm not sure. I think definitely on the administrative side, we'll turn the keys over, but I don't think we're anywhere close on the clinical side.
It is interesting to think about, right? I think, it will happen on the phone tree kind of style agent. I think it's already happening today in some respects. It'll be interesting. It's interesting when you think about these bots because they're becoming so informed that you actually can tell them that as part of their programming, if you want to call it that, where you're like, hey, I want you to have this voice and I want you to have this risk. And if there's any risk, then I want you to elevate it to a human, right? Like, you can kind of instruct it that way. And it does a pretty good job of doing that, right? So it is interesting that you can tell it that, and you will, right? You'll be afraid because of some of the risk. And so you'll tell it like, hey, it's going to escalate to a human probably more than it should. And that's probably a good thing. The other one to think about that I was pondering was how about like an autonomous agent in a hospital room?
Mm.
In the room that's interacting with the patient. The nurse can come by what, a couple times an hour, maybe, right? Once an hour, depending, on how many they have and what's going on. Do they need to come by? All those things. But you could have an AI agent there the whole time, having a conversation with them, having that discussion, getting information like, oh, where are you hurting? Where are you sore? Oh, you're thirsty. Like all those things that, might have been a nurse button push, right? And then it could just summarize that for the nurse. So that would be really interesting having like a full-time nurse. And I say that carefully because nurses are better than agents in so many ways. But having a full-time agent there that's collecting information that then makes the nurse's job easier, that would be really interesting to see, and it would be pretty autonomous, and it would be thoughtful and more so collecting data as opposed to providing treatment. And so that's why there's not the same risk.
Yeah, but I think you hit on it before. This is where I worry about AI in healthcare because I fear that it actually may turn into sort of a have and have nots. Because to me, the companies that are out there doing the fully autonomous AI doctors, that is solving a problem that was not meant to be solved by AI. It's solving the access problem. Well, I don't have a doctor. I can't afford a regular one. This is my alternative. I will put up with the AI doc because I can't get anything else. I can't get to see a real one, or I don't have enough money to pay for a real one. So I'll go with these alternatives. And when faced with that choice, well, yeah, I mean, that's a better option than not having care or not getting your question answered. But for is that really what we really want to be doing? Right. And to your going further with your example, you could see this happening with a care at home nurse. I can't afford a real one. I'll go with the AI one, right? Maybe I'm in a rural situation where where there's a shortage of nurses and they can't afford that many. So you are going to be taken care of for this hour, between this hour and this hour by a remote, today it's a remote nurse. Tomorrow it's an AI nurse, right? That's happening. So I just hope it doesn't become a replacement for solving the real problem. Like we just sort of put this on top because that's the only thing we got. But in actual fact, the real problem is, hey, like guys, like we need to even this out here where people get equal access to good care. And we're just using this because this is a better option, more efficient option, not out of necessity.
Well, it raises an interesting question. Is that a solvable problem? Right? Like, do we have enough humans to solve that problem? And if the answer is no, which may be the case, especially given licensure, and you don't just turn out nurses and doctors overnight, right? Maybe this is the best solution for them. So it'll be interesting. You're right, that may be the best solution, and you're like, well, that's not a great solution, but I'd rather have a human. But hey, that's the best we can do. That'll be interesting. I actually thought you were going to take it a different way. I thought you were going to say, hey, the large health systems with $8 billion endowment, they're going to be able to afford this technology and be able to put this in their exam rooms. And those that are rural health are not going to be able to afford it. And so then you have a haves and have not in a very different way than what you described.
And that's actually one of the questions coming up, John. But hey, listen, if you're just tuning in, you're listening to Healthcare IT Today with John Lynn and Colin Hung. And today we're taking a deeper dive into AI in healthcare. This week's episode is brought to you by Swaay.Health. If you're in healthcare marketing, PR, communications, or patient experience at a hospital, clinic, payer, health IT company, or agency, you need to be at our Swaay.Health Live 2026 event happening April 29th to May 2nd in Foxborough, Massachusetts. It's the premier event to learn, network, and get energized about healthcare marketing, communications, and patient experience. Head over to live.sway, that's sway with two A's, .health, and that's where you can learn more. So John, let's go to that one first then. Are we not talking enough about the cost of AI to your last point?
For sure. I mean, the only one I've seen kind of talk about it was Epic, interestingly enough, where they were implementing a model and, they were telling us, hey, we tried to implement it. I think they partnered with Microsoft to implement it. And they're like, hey, if we do this, they can't afford this. And they said, let's figure out a different model that actually works. And they did. They switched to a model so that then it could be affordable. We have kind of stepped away from this cost question in a somewhat reasonable way, because what we're hoping is that Moore's law kicks in. And when you look at the token prices, it seems like it is. And so many of us are saying, yeah, it's unaffordable now. We shouldn't pay what we're paying now. But if it goes like the rest of technology, it's going to lower in costs in a dramatic way where those costs don't matter. I don't know. Like the prediction on this is, do you think that Moore's law will kick in and the cost of all this AI will come down in such a dramatic fashion that it becomes negligible? The same way hosting and bandwidth have come down, right? Like those aren't issues now, right? We have enough bandwidth to do whatever we need. And the cost of it has come down in such a dramatic way. We're not on dial-up modems anymore, right? So if the same thing happens with AI, we're going to be just fine. But if it doesn't, which some people are concerned it won't, the data is going to continue to increase. The costs are expensive. Cooling's expensive. There's an environmental impact that I'm sure you'll love to talk about, right? Like, like this is a real question. And if it doesn't, then you're like, okay, now I have to start asking a very different question. I can do that solution, and that solution is better, but is it worth the cost?
Right.
We haven't had that question in very few areas of technology.
Yeah, this one, well, first of all, I don't think we're talking enough about cost, because right now, there's also no standard. Like what is good AI versus bad AI? What's affordable? Is affordable AI any better or worse than expensive AI? Like, it's the Wild West. So I don't think we know enough to even ask the right questions here, other than what's the final dollar value of what I'm getting in this product out of AI. I am worried, like you are, about, are we inadvertently creating haves and have-nots? What I look to in this kind of situation is I look at kind of what like robotic surgery has gone through, right? So at the beginning, only the most wealthy, largest health systems had robots to do surgery. Is robotic surgery better or worse than regular surgery? That's up for debate. I think the general consensus is robotic surgery it's safer. I don't know if it's better. I don't think the outcomes are any different. I just think it's safer because the robot is more precise. It can do things, and it can stitch you up, and it can do all the things where it doesn't need so. But now the costs have come down. To your point, the costs have come down. Enough people are skilled in it where it is now filtering into hospitals that couldn't afford the first versions, right? And now there's more competitors and so forth. I'm hoping that it follows the same road in AI, but I'm not sure it will. I'm not sure it will.
Yeah. It would be interesting to dive more into robotic surgery, because I think that is a good example of where we could be headed with this. And
Yeah.
why isn't there a robotic surgeon in every single hospital? That's a really interesting question. Like, it must be a cost and training. I can't
Availability,
imagine issue, right? Anyway, so that would be interesting to dive into, I think, because it would be very comparable. I go back to a conversation I had at a EHR user conference. I was sitting at a table having a conversation with them, and the CEO had just announced all these amazing features, of course, 90% AI. And I said, "What do you think of all the announcements? What's your reaction?" They're like, "Oh, I really loved," and I forget which AI feature it was. There was some AI tool that they had, and maybe it was the AI medical scribe or something like that, right? And they were said, "Oh, I really love that." But do you know how much it costs? And so they were realizing like, hey, the vendor's just passing the costs on to me. And then what they said is like, right now we can't afford that. Now, was that a wrong view, because of the efficiency that could come from that solution? Was that not a good leader that understands like, hey, it may cost $1,000 a month, but if it's producing $2,000 of savings, that's a good investment, right? Or, whatever it was. And maybe that's not the math, right? Maybe they did do a good job and they're like, yeah, at $1,000 a month, it's not reasonable, but at 250 a month, I would be okay. And so, maybe the vendor needs to come down to that $250 a month, right? Per doctor, blah, 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 right? But,
Right.
so it was interesting to see. They definitely were at the point. They're like, yeah, we'd love to tap into all this AI, but we can't afford it.
Well, let's get to the last question. This to me sounds like a very interesting topic just to have a whole episode on it one day. But let's get to the final one. That final question is similarly, are we not talking enough, or will we ever talk enough about the quality and diversity of data upon which all this health AI is actually trained on? Do you think this is going to be a major concern for people going forward, or will it ever?
It's interesting because in some ways, I think we talked about this more when we were doing like data warehouses and when we were trying to understand what data was stored in somewhere and how are we analyzing populations. So even with analytics, it was probably more of a topic because it made sense. If you have this data warehouse of white, predominantly white male and females in the Northeast, and we're trying to do analytics to understand a predominantly black population in the South,
Right.
like that wouldn't make sense, right? But when we look at the LLMs or even a lot of those different solutions, they have such vast amounts of data. We're talking about it a lot less. Is that a problem? I'm not sure. I don't know. Like it does have. I mean, most of the LLMs basically took the entire body of knowledge on the internet to create their LLM. Is that representative of most communities? I don't know the answer to that.
Yeah.
Like in the analytics, it was clear it didn't wasn't representative. In these LLMs, I don't know. I don't know. Do you have an opinion?
Well, I mean, so first of all, you know, I think I think AI can only be as good as our research data is available to it, and research data we know was biased. Right, we know that the data from most studies was biased. It didn't favor women. It didn't have a lot of ethnic diversity. So any AI that's trained to do that level of clinical knowledge that's based on research that's publicly available is inherently biased because the research itself was inherently biased. Now, did that prevent healthcare from taking advances and from helping people who did not match exactly who was in those studies? Of course not, right? We're pretty advanced. I mean, we did benefit from it, but was it representative? The answer is no. And I don't think we're talking enough about it because to me, it's not so much the ethnic diversity of that has been a problem. It will be a problem. And yes, we're going to run into a time where the AI is going to make a recommendation and it's actually not going to be very effective for a lot of people, right? Children, women, so forth. What I'm more worried about and concerned about is the social, economic, and geographic diversity of your data. Because when it starts making recommendations on treatment plans and treatments, and it doesn't realize that, hey, if you're making a recommendation for like this really sophisticated PT to recover from this type of surgery, which it recommended, and it's based on someone living in urban Houston, right, with an average income of $300,000 a year, to someone who lives in a suburb, in a suburban area with little access and an income one fifth of that. I mean, it's not going to make a lot of sense, right? You're going to say, wait a minute, like this is not going to work. That's what I'm more worried about right now as a more immediate concern, in terms of not having the discussion around how are these things being trained.
Well, one could argue that these solutions actually take that into account if we give them the right data.
Right.
right? Because we have to feed in the fact that you are affluent or you aren't, and what are the accessible options in your area for you to be able to get the treatments. So you could argue that these solutions could take that into account if we feed it the right data about our situation or
Right.
our status, whatever it might be. You're right, though. It is interesting to think about, like, so many of the drugs, right? Say not for pregnant women or not for children. And as I understand it, which I'm no pharma expert, as I understand it, the reason they put those disclaimers on wasn't because the drug wasn't effective for those two populations. It was just they hadn't tested it, so they
Right.
couldn't claim it.
Right.
And so, that's the interesting thing. And so, we'll see, we'll probably see the same thing with AI. Has it been tested for all of those populations?
Right. Right. Well, anyway, and like the drug example, is it still helpful? Yes. Right. It's still a good thing maybe that we have it. I just think we have to be having the conversations to know that this is like hallucinations happen. This is a boundary of what LLMs and AI is capable of, is that we don't have really representative data upon which we train these things. And on worse than that, a lot of companies don't even know the data that they're training their AIs on. Right? I've heard many companies make pitches through some of the other work I do. They go, "Oh, we trained an AI on a representative sample of patients that had this disease." And I go, "Great, where'd you get that from?" And their eyes glaze over. Well, we got it from from this organization or that organization. I'm like, well, where did that come from? And how do you know that it's good data? Just because it's branded by this organization that they provided the data publicly, still doesn't absolve you from needing to actually look at that data and go, is it any good? Right? Is it representative of the population you're designing a solution for? So I worry we're not having the conversation. I'm not as confident, obviously, about us solving it, but at least being aware of it can help you, to your point, bake in the design some ways to mitigate that problem, right? To feed in a bit of extra data to factor that in.
And maybe the message to all of this is the phrase you often hear. This is the worst AI we're ever going to have. It's going to continue to get better. We're going to have more data. We're going to understand it better. The technology is going to continue to evolve. So it's doing some amazing things now, and it's going to get better. So I think that's a positive thing as well.
Right. Right. Absolutely. After all, who wouldn't want more AI in our lives, right?
If the AI allows me to be more human, yes.
There you go. There you go. Well, thanks to all of you who tuned into this episode of Healthcare IT Today. You can find out more details about our show by checking out the programs page at healthcarenowradio.com. And please share your voice and engage with our community at healthcareittoday.com and on social media using the hashtag HITSM. I'm Colin Hung, along with my friend and Health IT collaborator, John Lynn. Thanks for listening, and have a great week.